Today topic of discussion anti-tuberculosis drugs. Tuberculosis or TB is a chronic infectious disease caused by Mycobacterium tuberculosis that needs to be treated over a period of time. Need to be treated over a period of time that can be month or even years. If you are still positive for tuberculosis culture, and as the TB is a chronic disease, that's why the lesions of tuberculosis is fibrotic and drugs penetration is a problem. So decreasing drugs penetration. The drugs that are used against tuberculosis can be divided into first line anti-tubercular and second line anti-tubercular drugs. The first line are of course used first and they are cheap, effective and with decreased dose toxicity, while the second line are the one used after the first line does not work and they are expensive, not that effective, also with increased toxicity. The first line anti-tubercular drugs include isoniazid, rifampin, pyridoxinamide, ethambutol, streptomycin. So first line drugs example isoniazid, rifampin, pyridoxamide, ethambutol and streptomycin. While the second line anti-tubercular drugs include fluoroquinone, amikacin, cycloserine, ethinalamide, then ferraminosalicylic acid and capreomycin. So fluoroquinone, amikacin, cycloserine, ethinalamide, isoniazid. It acts by inhibiting mycolic acid synthesis. That is an essential part in the cell wall of Mycobacterium tuberculosis. So mycolic acid synthesis, that is essential part in the cell wall of Mycobacterium tuberculosis. Now this isoniazid is a prodrug that depends upon bacterial catalyst for its activation. If we are depending upon that bacteria, so bacteria has the power to mutate that CAT gene or inactivate and thus become resistant to these drugs by not even activating its active form. It can kill both intracellular and extracellular bacilli and thus is used both in treatment and prophylaxis. The pharmacokinetic properties include that it can cross the blood CSF barrier, also placenta and also tubercular cavities. It is metabolized by acetylation in the liver and thus excreted in urine. Its metabolism is dependent on slow and rapid acetylator. Its side effects include hepatotoxicity, that is because as it is metabolized in the liver and These drugs are used on a chronic basis. That why this hepatic toxicity is there. It leads to arrays in AST and ALT. Liver function test, AST and ALT level will increasing. That ALT is required pyridoxine, that vitamin B6 for this activity. That's why they will depleted the vitamin B6 leads to peripheral neuritis. It leads to peripheral neuritis. Other side effects are sideroblastic anemia, SLE, systemic lupus erythematosus, that mostly associated with slow acetylated and hemolytic anemia in glucose 6 phosphate deficiency patient. Now, vitamin B6 is also required in the synthesis of heme. That is not synthesis. Iron get deposited in that RBC leading to sideroblast formation. And thus sideroblastic anemia isoniazid is also associated with SLE just like many other drugs because it can bind to carrier protein and act as heptan and thus elicit an immunological response against the body's own cell. Lastly, we know that glutathione is a glutathione is a triple peptide that is an antioxidant. Glutathione is a triple peptide that is an antioxidant. Now what happened when glutathione has taken care of that oxidative stress in any cell? It needs to be reduced into its active form. So in order to convert that oxidized form into reduced form, we need NADPH. And now this NADPH comes from glucose 6 phosphate in that pentose phosphate pathway. Now, if the person is glucose 6 phosphate deficient, then this glutathione will not be converted into its reduced form and that oxidative stress will not be taken care of. That's why glucose 6 phosphate deficient patient there will be hemolytic anemia. So glucose 6 phosphate deficient glutathione will not be converted into its reduced form and thus oxidative stress will not be taken care of that. That's why glucose 6 phosphate deficient patient there will be hemolytic anemia due to oxidative stress. Now glucose 6 phosphate will be there in all the cells of that body. Then why are RBC are more susceptible? The reason is because RBC does not have mitochondria. They have no sources of reducing power apart from glutathione. They totally depend on glutathione to be converted into its reduced form by NADPH and thus on glucose 6 phosphate dehydrogenase. Coming to rifampin, it also called as rifampicin. This is also known as sterilizing agent because it acts on both intracellular and extracellular and also on the ones that are presented in case of necrosis. It acts by inhibiting DNA-dependent RNA polymerase and that polymerase RNA synthesis. So inhibiting DNA dependent RNA polymerase and RNA synthesis. It is bactericidal of Mycobacterium tuberculosis, Gonococcus, Streptococcus aureus, E. coli, and Pseudomonas. Then pharmacokinetics, food decrease its absorption, it's metabolized in the liver by acetylation, and thus the soluble form is excreted in the urine. So soluble form is excreted in the urine while the unmetabolized form is excreted in the bile and undergo entire hepatic recycling. It can be used in the treatment of tuberculosis as well as leprosy, meningococcal carrier state as well as brucellosis treatment. That worst effect will also include hepatotoxicity. It also causes flu-like symptom, gastrointestinal disturbance, skin rashes, itching, flushing, etc. Characteristic red orange color in the urine, tears and saliva. They are harmless, so the patient need to be educated. Rifampin is also the an enzyme induces its own metabolism. Next, by resin amides act by inhibiting mycolic acid synthesis but not with the same mechanism as isonic acid. It causes dose dependent hepatic toxicity, hepatitis, also hyperuricemia because it competes with uric acid for secretion in the kidney. It competes with uric acid for secretion in the kidney. Next, ethambutol inhibit arabinogalactone synthesis. Inhibits arabinogalactone synthesis by inhibiting the enzyme arabinogalactose and the cell wall synthesis inhibition because this arabinogalactone is the major structural component of microbacterial cell. Microbacterial cell wall. It is bacteriostatic drugs and it has no cross resistant with any other anti-tuberculosis drugs. It can also be used compact Mycobacterium avium complex. It can cross the blood-brain barrier and can be used in many meningitis treatment. Next, streptomycin for tuberculosis patient are given. These streptomycins are given intravenous or intramuscular in hospital. Then fluoroquinones can be used are ciprofloxacin, ofloxacin, moxifloxacin and levofloxacin, and they are all bactericidal in nature. So fluoroquinolones used ciprofloxacin, ofloxacin, moxifloxacin, levofloxacin. They are all bactericidal in nature. Next, amikacin. It are also given intravenous. It is a sidal drugs. Next, cycloserine is a cell wall synthesis inhibitor and can be present, can cross blood CSF barrier and has CNS side effects such as tremor, psychosis, convulsion and headache. Next, ethylamide which is same as isoniazide, the structure, but has reduced efficacy. It also inhibit mycolic acid synthesis. The side effects include epigastric pain, hepatitis, and blurred vision. Next, regimens for treating tuberculosis. Firstly, normal course therapy. Normal shot therapy is for about 6 to 8 months. It is convenient, highly effective, and less toxic. It comprises of an intensive phase and continuation phase. That intensive phase is 2 to 3 months, while it continuation phase for 4 to 6 months. In this intensive phase, we use 4 drugs, and in that continuation we can use 2 drugs. For both of them are silent, and then they can be given daily or to improve patient daily or thrice in a week. Necessary in TB management and treatment. We can give it thrice a week. The intensive is to render that patient non-contagious, while that continuation phase is to prevent relapse by eliminating the remaining microorganism. Second one is multi-drug tuberculosis is the one in which that organism has resistant to both isoniazid and rifampin, with or without resistance to any other anti-tubercular drugs. In this case, we can use drugs with known susceptibility to that organism. It also considered of an intensive and continuation phase. In this intensive phase, 6 drugs for 6 to 9 months, while this continuation phase 4 drugs for 18 months. And don't forget pyridoxine to prevent the peripheral neuritis. Pyridoxine to prevent peripheral neuritis. Next, drugs ostensibly drug resistant XDR. Tuberculosis is one of that resistant to isoniazid, it rifampin fluoroquinones. One of any case in this one is fatal in that HIV patient. It will causes death to HIV patient. Then HIV patient with tuberculosis prefer rifampicin analog, but it has less enzyme inducing activity, so it will not enhance that metabolism of anti-HIV drugs. That we are using such a protease inhibitor, and that's why they are preferred, and a short course therapy should be started as soon as possible. After diagnosis of TB in HIV patient in pregnancy, all the first line drugs are used except streptomycin, which is contraindicated in pregnancy to eradicated. Then that Mycobacterium avium complex tuberculosis, we can use this clarithromycin fluoroquinone for 18 to 24 months. So this is all about anti-tubercular drugs. Thanks for watching.